Hi everybody, thanks again for joining me on our lunchtime webinar. Hey, I want to review a couple things before we start, and actually I'm going to launch a poll at the same time here, and I'm going to let people respond to this. I wanted to talk about a couple of things. I actually did get an email from somebody who is not going to be able to make it today, which is fine, about some questions, and if folks want to email me, you're more than welcome to. But I wanted to make these quick points. The first one is that as part of talking about with your patient, what happens if the line goes out completely? So if the picture freezes or you lose internet connection, one of the things you also need to be cognizant of is that sometimes maybe your picture will go out, or you won't be able to see your patient anymore, but you'll still have audio. So you just need to let your patient know ahead of time. If they ever lose picture, just let you know, and if you lose their picture, you need to let them know. One of the things that you could probably do in that situation is just have the person, again, I'm most familiar with DoxyMe, but get out of DoxyMe, sign out of the session, and then sign back in, and that usually works well. Now, someone who was talking to me at one of my presentations said that a patient told him, it was a male psychologist, female patient, that the picture of him went out. And so he just thought, okay, my picture went out. Unbeknownst to him, his picture came back on. But what he was saying is that he was picking his nose, he actually put his head down on his desk, he was like shaking his head no, he was doing other kinds of nonverbal things, and at the beginning of their next session, the patient brought that up then. And so the moral to that story is always believe that your camera is on. Even if your patient says, I've lost video of you, say, we'll let it go for a couple minutes, maybe we'll have to reboot, but always believe that your picture is on. The second thing, I hope I said this yesterday, was to purchase a decent set of headphones with a microphone. So even if you're going to use a laptop or your desktop, and especially if you're going to use your phone, buy a decent set of headphones with a microphone, because what I found in my practice is that I felt like at times I was yelling at my patients. So I can't remember if I said that or not yesterday. I didn't kind of check it off my notes. So I wanted to make sure that I said that. Now, as part of the email that someone sent, they were talking about bandwidth as it applies to routers. So one of the things that happens, and this is very true, is bandwidth is important, but also your router is important. So again, it's not only your router, your patient's router, because there's this phenomenon called bottlenecking. So if you have, like, say, 50 megabytes of upload speed or download speed and 10 megabytes of upload speed, but your router only handles 2, that's where the bottleneck comes in, and you'll only be able to do, in spite of the fact that you have much more bandwidth. So that's another equipment issue. So what engineers are trying to work on is not only expanding the bandwidth of what goes through the pipe, but also what they're working on is compression. So compression is when they're trying to minimize the information, but sometimes when you minimize that information via compression, you actually lose some quality. So the best example I can give of that is when I start talking really fast, I'm trying to compress information, and then sometimes I forget to mention some of these things. So it might be interpreted as I'm feeling a little anxious, which I am, to get the information out, but I'm trying to compress the information, but sometimes when you compress, you lose some of that information or that quality of information. So that's why I'm going back and reviewing a couple of these things. So hopefully those points make sense, and we'll keep moving forward. Okay, so here is the web address. You do not have this slide, unfortunately, but that's my web address, ethicalpsychology.com. You can follow me also on Twitter. I do a lot with ethics education. But the other thing that I think is very important is my SlideShare account. And this is my SlideShare. There's my SlideShare account. So it's www.slideshare.net/GavazziJ, and all of my presentations are there, my ethics presentations, and all 3 of these will be there. So if you're afraid that you might lose a file, you can always email me, call me and say, what is that, what's your SlideShare account again? And you'll be able to find this presentation and many others. Okay, so a quick review of our last session is we went over some definitions, and you can see all the definitions that we went over. We talked a bit about competence, and this was more in terms of technological competence, in terms of things like, you know, Wi-Fi security, synchronous versus asynchronous, knowing your platform, and then also the delivery of telepsychology services in terms of, you know, what's involved in doing an assessment, trying to figure out if in fact the patient is an appropriate candidate. If so, why are they? If not, why not? And, you know, making sure that you're providing the same level of care as if it were face-to-face. So again, that's what we went over last time. So the learning objectives for today, at the end of today's session, you will be able to, number 1, understand important components of informed consent. Again, if I can clarify this a little bit more, as this applies to telepsychology. Number 2, list 3 key features of risk management. And number 3, outline what SIPAC is and why it may help your practice. And then if I have time at the end, I have an ethics vignette. Like I said before, I always have probably too much information. I also do want to talk, I'm going to write a note to myself now, I also want to talk about legislation that I didn't talk about yesterday. So we'll just continue on and go forward. Okay, so informed consent. Now, again, if you look at the telepsychology guidelines, they don't tell you, because they're guidelines, they're aspirational, they're not enforceable, they don't tell you exactly what you need to put into your informed consent speech or document, but they do give you topics to contemplate, and that's how I'm framing it. So when you're thinking about doing telepsychology work, the first thing you need to remember is that you need to use all of the good, regular, face-to-face information related to informed consent. And again, these things include, but are not limited to, cost, how much is it going to cost them? And one of the things that I do ahead of time is I check people's insurances and I look at co-pays and I say, you know, these are the things that you're looking at. So, you know, that's important. You know, what are the benefits to psychological treatment? And again, that's psychological treatment in general. We're not talking telepsychology yet. What are the risks of psychological treatment? Talk a little bit about confidentiality and its limitations. Background, your education, your training, how you approach psychotherapy. And an important part, as we're going into now some of the telepsychology stuff, an important part to remember is that telepsychology is still considered an innovative practice. So the idea is that, you know, the idea is not to select telepsychology as necessarily your first line of intervention. So telepsychology can be used as a first line intervention, again, under certain circumstances, and we talked a little bit about some circumstances when it would be appropriate, like an agoraphobic patient. But again, I want to remind you, just because you have this tool doesn't necessarily mean that all people are going to be able to benefit from it. And in fact, using telepsychology might actually be harmful. So now let's move into informed consent with telepsychology. So this is now, I break it into 2 parts, is what about you as the psychologist that you're agreeing to, and then we're going to look at what the patient is agreeing to. So the first thing you're agreeing to is to use a HIPAA-compliant platform. And if you don't do it, again, this is more risk management because, again, I strongly recommend that everybody use a HIPAA-compliant platform. But as one of the questions was yesterday is, well, what if I choose to do something that's not a HIPAA-compliant platform? Again, you're engaging in a higher risk activity, and if that's the case, you still need to inform your patient either you're going to engage in this activity using a non-HIPAA compliant platform and also explain the risks. So you need to understand the risks mainly in terms of security. Okay? So you also have to explain what to do in case of lost transmission. So again, if your internet goes out completely, what do you do? Or if you lose audio, what do you do? So that needs to be spelled out ahead of time. I'm only going to answer this question because it's a question from Monday when a psychologist is splitting year between two states. Yes, we're going to be covering that later. That'll be in part 3. Promise I'll get to it. The next thing is to develop a safety plan in advance if the patient cannot get to your office. So as I said before, you're at greater risk with greater distance from your patient, and if you don't know that community. So typically when I do psychotherapy face-to-face, I don't talk about a safety plan. But if you're working with somebody kind of like in a pure telepsychology play, you really need to get that done if they live more than however many miles away that you feel that that's important. Again, my risk tolerance might be different than your risk tolerance. So for me, it might be 15 or 20 miles, and you as a practicing psychologist say, well, I can look that up. I'm in Philadelphia, but I can see someone in Erie. That works too. You just have to do it. I should say have to. The guidelines recommend that you do it ahead of time. So also, you need to develop a plan if the patient needs face-to-face sessions. So if something's happening where the telepsychology services aren't working out, the patient may need face-to-face. And as I talked about yesterday, that's part of your obligation in engaging in telepsychology services is to continually evaluate and reevaluate if the patient is benefiting from treatment, because if not, then you need to come up with another plan. So if the patient lives close to you, the patient then can come to your office. I think that's a simple, very simple solution. If the patient lives too far away from you, do you have a colleague, or can you refer that person to someone within an appropriate time frame I have here, but also who accepts their insurance and has some level of expertise, so in whatever their condition is. So again, this is why seeing people at a greater distance provides you with greater legwork and potentially greater risk. All right, also on your side as a psychologist, developing the emergency plan for patient crisis. So this includes, again, this kind of granular information. Does the patient have the numbers for crisis intervention in his or her locality? Are you, as the psychologist, familiar with the hospitalization procedures in that area? So do you know, what the process is, where they would need to go, where your patient would need to go if they went into a crisis situation? And as importantly, what would you do if an involuntary commitment is needed? Now, the reason I'm bringing this up is because I would say about 6 months ago, I needed to 302 or petition, do a 302 petition for one of my patients. So I actually had to go to the emergency room to do that. So if I'm in, say, where I work is Cumberland County, and say that I'm seeing a patient in Lackawanna County, would I have the ability for them to fax me paperwork, or would I need to physically drive up there and show up in person to do it? Again, these are unanswered questions, but these are things for you to think about. And again, the reminder is, with greater distance comes greater risk. So what you're also doing is you're agreeing to that you will use a similar treatment and similar treatment procedures and interventions via telepsychology as you would with face-to-face treatment. So if you are there, and again, as I gave the example before, you think the camera goes out and you're going, and like you're answering emails or you're checking your Twitter feed, I mean, those are really not what you need to be doing. You need to do exactly as the same. Now, again, as I gave the example before, if you pick your nose in front of your patient, feel free to have at it. I mean, if that's the way you do therapy. But the idea is that you're giving them as close to as possible the same interventions. What you're also going to agree to is that you're going to agree not to record the sessions. So again, usually in face-to-face, if I were to record a session, I would ask my patient's permission. But you're just saying, I'm not going to record these. It's very easy, if you know the technology, it's very easy to record your screen without anybody else knowing. And you are agreeing that you're going to be the only person in the room when conducting telepsychology services. So whether it's your home office or your office, like the secretary or your assistant isn't coming in or out, colleagues aren't coming in or out, that when the door closes, and it's a psychotherapy session like any other psychotherapy session. So now on the other side, what you're asking the patient to agree to is you're asking the patient that they will agree also not to record the sessions. And again, this gets a little dicey because there is a trust factor involved, because what if somebody is recording your telepsychology sessions and then they're going to use those as part of some kind of legal action against you? So again, I'm not a lawyer, so I don't know what all the ramifications of this are, but this is what you want as part of the agreement. They're not going to record the sessions. Also, your patient needs to agree that they are the only person in the room or their office when you're conducting telepsychology services. So their sister isn't sitting under the desk, or mom isn't on the other side of the computer where you can't see her, or a spouse is in the room. Again, you want to make that as consistent as possible with a regular psychotherapy session. Again, if you want to do couples counseling with via telepsychology, that's different. You can do that, but again, this is the agreement. So the patient also needs to agree that if you request, you as the psychologist request, the patient will move their camera around the room to ensure confidentiality. So that's something that, again, if you're feeling something is not quite right, you need to have their buy-in that that's what's going to go on. So the person is also agreeing, the patient, I'm sorry, is also agreeing that they are in the state or jurisdiction that she or he says she or he is in. So again, this is how you're trying, this is part of the risk management, but this is also part of informed consent, to make sure that they're not somewhere where they say they're not. Because again, on DoxyMe, you can hop on it, Indiana, Pennsylvania, the state of Indiana, or they can be in India, and I wouldn't know the difference. And again, they're going to agree to only use secure networks. If not a secure network, you just have to discuss the drawbacks, and their data, their confidentiality, their privacy is at risk if they don't use a secure network. Okay, so in terms of documentation of informed consent, hopefully everybody knows this. In Pennsylvania, you do not need to have a written informed consent sheet that people need to sign. All you need to do is provide them informed consent, and then you document what you provided in terms of informed consent. For myself, with face-to-face psychotherapy, I do have a written informed consent sheet. And at this point, go down to bullet point 4. No, I don't have one yet for telepsychology. I'm probably going to be working on one here in the next month or so, using some of these points that I'm making today. So it probably is a good idea for everybody to generate some type of written informed consent procedure for telepsychology services. if you are an APA member, APA has a real nice model from which you can draw your own face-to-face informed consent sheet. Okay, so that's what I have in terms of informed consent. So if you notice that there are some things that are different than regular face-to-face psychotherapy, so there are some differences. Okay, so I'm going to answer, I only have one question at this point, which is great. Any pointers on how to handle termination of treatment if done through telepsychology? And I think it's a great question. I'm not sure exactly what you're looking for in terms. Maybe you can re-ask the question, but I think as best as possible is to go through the same type of termination process that you would do in face-to-face therapy. So you might want to say that, hey, it seems like you're getting a lot better in treatment. Again, if this is a pure telepsychology play, and you know, it seems like we've accomplished our goals. You know, I think I'm ready to help you graduate, and you know, if you ever need me, you can go ahead and call me back. Again, I don't say it this succinctly, but that's the idea. Maybe the question has to do with terminating treatment if you're finding telepsychology is not working. And I would say the same thing is that, you know, I think we need to start, if they're close enough, we need to start meeting face-to-face, because it doesn't seem like doing telepsychology work is being very helpful at this point. Or if they're at a distance, you might say that, you know, hey, I don't think things are going tremendously well. Let me refer you to somebody, you know, in your area that you can continue this with face-to-face. So I hope I answered your question. If not, JK, I apologize, but if you want to go ahead and ask it again in a different way, but that's those are my thoughts. Okay, so let's move on to risk management, and I don't feel any need at this point to do any compression. Right on time. Okay, so these are just some risk management reminders. So it's important for you to provide comprehensive informed consent. And again, we just went over a bunch of bullet points. So these are things that you would need to incorporate into your informed consent process. And Sam Knapp and I wrote an article on this in the PA Psychologist. There was actually another article written in the American Psychologist that the idea is that informed consent is not a once and done process. So in other words, just because somebody signs the informed consent sheet, or just because you give them informed consent sheet, that's not when it's over. That informed consent goes throughout psychotherapy. So hopefully, especially if you run into any difficulties, you can go back and remind people and say, if you remember that we talked about this at the outset, that if you share with me that a child is being sexually abused, I need to inform someone. So that's just one example of many. Or you can talk about, on my when we talk about informed consent, we agreed to doing a 50 to 55 minute session, and you're going over, you're taking an hour and 5 minutes that we're going to need to close this down at 50 to 55 minutes. If you need twice a week because you have so much stuff to do, if you need twice a week because you have so much work to do, then we can meet twice a week. So that's another example. So you also need to develop, whoops, why did that happen? You also need to develop appropriate documentation of your assessment and your sessions. So make sure that you put down some type of note or assessment as to why you think telepsychology is appropriate for this patient, and just a line or two that says that you believe that the person is still benefiting from telepsychology. Because again, that's part of the guideline, is that you're constantly monitoring to make sure that this is the best form of treatment, again, mainly because it's an innovative practice. Okay, and hopefully everybody can see the bottom of my screen. It says, consult knowledgeable others when you have questions. Okay, so some other risk management reminders. Are you competent to provide these services? And then how would you know? So this is a thing, an idea that I keep bringing up throughout the training, is competence is really hard to quantify. But the best way, and again, I know I'm repeating myself, is to use the migration model, is to work with one patient. Well, again, get up to speed with your security, read through the guidelines, do all that good prep work, introduce it to a patient, start working with one patient, make sure that their insurance covers it, make sure they're comfortable with it, think about the reasons that you want to work with this person from a telepsychological perspective. Mainly it's for patient convenience, so you think about somebody who's got lots of time restrictions, and this can be a better convenience for them, and then you can start working with one patient to see how it goes. As I said before, you need to know your hardware and software comprehensively, and obtain more intensive training to engage in services. One of the things that Judy and I talked about later yesterday afternoon is I'm thinking about doing, because of how we did this and how many questions we had, I'm thinking about doing something at the convention that's a little bit more hands-on and a little bit more time, so we can get into some more issues, so people feel a little bit more comfortable and a little bit more confident in their abilities. So in terms of risk management reminders, you need to think of the CIA, which is not the Central Intelligence Agency, but confidentiality, integrity, and availability. And this is what they talk about mainly in terms of records. So confidentiality, are you protecting information from unauthorized disclosures? Again, with telepsychology, it's the same thing as regular face-to-face confidentiality. Integrity, are you preventing third parties from altering your clinical record? And the reason I brought this up is because as people are moving to electronic records, this is something that you need to think about. So how secure are your records, even in the cloud? So making sure that whoever you're working with, which again, I would say 95 to 98% of people who are doing electronic health records are HIPAA compliant. But again, just because something is HIPAA compliant, just like DoxyMe or anything else, doesn't mean that it's always totally going to be secure, that everybody's doing the best they can. Again, just like in face-to-face, somebody can break into your office and steal your computer or steal your actual physical records. I mean, that does happen. And the last thing in terms of risk management reminder in terms of records is availability. Are you making clinical data available to authorized parties in a timely fashion? So one of the questions I get frequently is, can I email information to my patients versus like faxing? And so if you have a psychological report on somebody, can you email it? My response always is that you need a secure email to do that. And there are free services, email services. There are ones that you can pay for as well that provide HIPAA-compliant emailing services. Excuse me. Sorry about that. But your best bet is usually faxing. And when you fax, again, just make sure that you have the right number. Okay, so again, you're probably sick of me saying this. There's a correlation between distance between you and your patient with risk level. Again, you have to determine your own tolerance, your own risk tolerance. There's also a correlation between patient complexity and risk level. This is also true with face-to-face psychotherapy, but it's also very true with telepsychology. And there's a correlation between your knowledge of community support and quickly accessing support and risk level. So again, if I moved from Erie to Central Pennsylvania and I knew everything that was going on in Erie, and I came to Central Pennsylvania, I would feel very comfortable with that. If I'm not from Erie, so if somebody from Erie wants to, seek services from me, I'd have to think long and hard about that. And also make sure that you bill insurance companies accurately. So this goes back to day one when we talked about different insurance companies have different billing strategies for telepsychology services. So make sure that you know what those are and make sure that you're using those accordingly, because again, those are good risk management strategies. Okay, so the question earlier is we were going to get into interjurisdictional practices. That's where we're going next. But I see I have a bunch of questions. And any thoughts on no-shows for telepsychology session in your consent? I would say it's the same thing as whatever your face-to-face no-show policy is. Some people charge the full fee, some people charge half their fee, some people charge $25. You know, whatever your policy is, I would try to keep it as consistent as possible. Again, I'm repeating that, underlining it, bold it. Whatever you're doing face-to-face really needs to be as similar as possible as to what you would do with telepsychology. Would you be willing to review and comment on my initial attempt at informed consent at the evaluation form that I am using to document that teletherapy is appropriate for a client? Would you be willing to review and comment? Oh yeah, absolutely. So if you want to, I think that's what you're asking me. If you want to send me a document, yeah, I'd be more than happy to look over it. And in fact, maybe I'll steal it too and use it for myself, or we can work on it collaboratively and come up with a document. Absolutely, I'd be willing to do that. Do you know of any telepsychology readiness tool to use? I don't think so at this point. Again, I mean, I can Google it. I'm not going to do it now, but I mean, I can Google it and send you an email. But I think, again, this is more of thinking about expanding your practice to include something else. So let's say, again, I'm a CBTer primarily, a little bit more eclectic, but I use a lot of CBT approaches. But say I really wanted to do a lot more with interpersonal psychotherapy. So what I would do is I would read a lot, I would go to trainings, I would start practicing some of it, and maybe I would get some consultation from somebody who I know who does this, like maybe a training or an article that I read. I'd get some consultation. But I think that's the idea is, start low, go slow, and, make sure that you, again, are documenting as much as you can to show that what you're doing is consistent with what you would do on a face-to-face basis. Do you or PPA have examples of assessment tools to ensure telepsychology is still beneficial? Again, I'm not aware of that. I think that's a great question. But what I typically do in psychotherapy face-to-face, and I do this with telepsychology as well, is after every 4 or 5 sessions, I usually say, hey, how are things going? Do you want to give me feedback as to how I'm doing? Are there things that I'm doing that you don't really appreciate or you don't think is helpful? Or are there things that I'm doing that you really think are helpful? So I do the same thing, with telepsychology. After every couple sessions, I would, try to solicit feedback from patients. Now, again, you can go ahead and, if you felt comfortable, sending them a link to like a survey that you have that's anonymous, or you give them like a number, a code number like 1 or 2, and you know who they are, and then say it's not anonymous, but you want them to fill out some scale or some kind of assessment. That might help you make a decision too. But I think that's an excellent question. Could you please identify the free email service? Okay, so I don't know any off the top of my head, but what I would suggest is just email free HIPAA compliant email services, and you should come up with a list of them. Again, I'm not trying to absolve myself from responsibility here, but I think it's you could probably go ahead and do that as quickly as I can. A little off topic here, but you commented on free HIPAA compliant, same thing. I've not been able to find any such services. Can you please list a few? Okay, what I will do is I will put a post on the PPA listserv for the free email services. Okay, so now hopefully the person who asked the question will finally at least get not necessarily the answer, but some of the answers or some of the ideas to start thinking about in terms of interjurisdictional practices. Okay, so the idea here is that especially those people who work near the borders, as I talked about, of Pennsylvania, will typically see people who live in either New York or New Jersey, Maryland, Delaware, West Virginia, Ohio. I hope I hit them all. And sometimes it's kind of a pain if you are seeing them and they would have to travel into your office across state lines. So that's kind of the issue. So intra-jurisdictional practice, that means within the domain or the boundaries of the Commonwealth. There is nothing in the state board regulations that prevents psychologists in Pennsylvania from providing telepsychology services here in Pennsylvania. As I said before, you're sick of this, you are at greater risk with greater distances. But what about neighboring states? And what if you move to Pennsylvania from another state? So these are some great questions. So here again, we've already had some of these questions. What are some of the concerns about interjurisdictional practice? Okay, so are you licensed in the state that the patient is in? And if not, why not? Because that is going to be something that's very important when we get down to these next couple ideas, because if a patient presents with child abuse concerns, and hopefully everybody here is familiar with the fiasco that's going on here in Pennsylvania. In fact, if I lived outside of Pennsylvania and I heard what the child abuse reporting requirements were in Pennsylvania, I would really think twice about practicing in Pennsylvania. And I'm saying that half tongue-in-cheek, but I'm also, fairly serious, because it's really bizarre, some of the things that we would have to do. So again, if a patient presents with child abuse concerns and they're in Pennsylvania, we all know what to do. But what happens if they're living in Delaware? What happens if they're, you're seeing them and they're in Delaware, like physically located in Delaware? What if they're in Kentucky? Do you know that state's law? Because it's very important for you to know what those laws are, because child abuse reporting requirements vary from state to state to state. So also, what about if a patient becomes imminently suicidal or homicidal? Which state's law comes into play? And do you know, again, that state's law? And practically, do you know exactly what you need to do? So hopefully everybody understands in Pennsylvania, if somebody comes as a homicide risk and you really do think that they're going to kill somebody, what are the steps that you need to take if you do believe that they're an immediate threat and they have the means to carry out that threat, the person's in imminent danger? Do you know what you need to do, and do you know when your duty has been discharged? So again, for different states, there are different requirements. So it's probably better for you if you were licensed in that state at one point, or you get licensed in that state as soon as possible, so you know the answer to these questions. Now, I'm giving you fairly dramatic examples, but let's take a less dramatic example. What about record-keeping guidelines? And if you are licensed in more than one state, you'll probably know that, again, something as mundane as record-keeping guidelines vary from state to state. So not only what is contained in the record, but how long you need to keep that record. So those vary as well. So those are some things to think about if you want to practice interjurisdictionally. Okay, so now here are some interesting questions. What if your patient travels to another state for business? Can I see that person? And again, I think the best answer, the absolute best answer is, if you're not licensed in that state, it's probably not a good idea for you to do that. And that's the best answer. But then you say, well, they're only there for a week. Why can't I just see them for one session? Again, you're starting to elevate your level of risk for, again, something bad to happen. So that's something, again, you have to evaluate your own risk, whether you want to do that or not. What if your patient lives in another state but works in PA? And we covered this the other day because somebody had a question. If they're physically in Pennsylvania, you can work with them either face-to-face or through telepsychology. But once they cross that border and they go home, and say they're sick one time and they can't make the session because they feel sick, but they said, hey, if you have a HIPAA-compliant telepsychology platform, I can hop on that while I'm here in Maryland. Again, do you have the risk tolerance for that? Yes or no? And some people say, no, I don't want to do that. And other people say, well, if it's just once, I'll go ahead and do it. But that's your own value system. That's your own risk tolerance. The safest answer is to say no, because it's not, at this point, it's not acceptable for people to practice in states in which they're not licensed. So what if a psychologist temporarily travels to another state to take care of a sick relative, and when I came up with this scenario, I'm thinking, weeks or a couple of months. Can she or he still practice telepsychology with his or her patients in Pennsylvania? I don't think that issue has been resolved. From my perspective, I would say yes, probably, because again, the idea is that you're trying to be beneficent toward your patients. You don't want to have to refer them. You don't want to interrupt treatment. You're technically not practicing in a state you're not licensed in. So in this scenario, as I would work through it in my mind, I would say that seems to be acceptable. But again, I'm not a lawyer, and I can't say that's completely correct. What the laws say is that you can't practice in a state where you're not licensed. It doesn't say that you can't practice in the state that you're licensed if you're not physically there, if that makes sense. So again, what if the psychologist plans to spend an extended period in another state for any reason? What are the concerns about continuing practice? So again, I think I kind of addressed that. So, if you're licensed in that state, you can practice in that state. That's the way that I read these. Okay, so Dan asked about the Association of State Psychological and Provincial Boards, otherwise known as ASPBB. And they are working hard on that, and I want to thank Dr. Alex Siegel for providing some of this content, not all of it. He is, I can't remember what his title is, but he does work for ASPBB, and he filled me in on SciPac. Okay, but SciPac is an example of a compact. Okay, what is a compact? A compact is an effective means of addressing common problems. In this case, expanding access to psychological services, through, psychologists in Pennsylvania. Typically, reasons for a compact include creating economies of scale, and thereby people save money. But that really doesn't go on with psychology, because we're not really creating, at least not that I'm aware of, that we're creating an economy of scale. But what it does allow is it allows states to combine their forces, belong to a collective, so to speak, but still retain sovereignty over what goes on in their state. So again, the idea is that compacts have been around for a long time. This is not anything new, and I think this is why ASPBB is trying to move forward with this. And again, I'm going to talk, other professions are doing this too. So compacts are essentially treaties between two or more states. And there are a variety of ways that compacts come into existence. The key feature here is that psychologists will be looking at legislative efforts to make this happen. So I'm going to go back to session 1. And I said that Penn SciPac is working hard to influence legislators to make sure that all insurance companies reimburse for telepsychological services or telehealth services, of which telepsychology is one. So we're putting pressure, we're advocating, whatever phrase you want to use, for legislators to agree that this is a good idea. I think it's a good idea. Probably everybody on this phone call or this webinar thinks it's a good idea. So that's why we have to pool our resources and move forward with that legislation. So that would be step 1. Step 2 would be legislative efforts to join SciPac. Okay? The benefit of doing this through legislation is that legislators understand compacts. Compacts are very flexible, but more importantly, they're enforceable, and they're an enforceable means of cooperation. So again, this would really help out psychologists around the borders of Pennsylvania if Pennsylvania and these other neighboring states would join some type of compact. And again, compacts are not mysterious. So in the United States now, there are more than 200 compacts that already exist. And you might be saying, John, can you give me an example of one? Certainly. The New York, New Jersey Port Authority. Now, you might remember this. Again, I bring politics in every once in a while. But that's one of the reasons Chris Christie's in trouble, or potentially in trouble, is because of some of the political shenanigans that may have gone on around the New York, New Jersey Port Authority. So I'm not saying that compacts are bad. I'm just saying that sometimes compacts are politically complicated, and they're highly politicized in many cases. I shouldn't say in many cases. In some cases, they're very politicized. Okay, so what other health professionals are developing interstate compacts? Well, right now, medicine, physicians are trying to develop compacts, mainly because there was a court decision in Texas for medicine that basically said, much like I talked about with Ohio, but there was a court decision to say that, you know, physicians can't do telemedicine in Texas unless they're licensed in Texas. So that was one of the key decisions why medicine is now trying their own compact. Nursing is trying to do their own compact. Physical therapy is trying to do their own compact. Okay, so SIPAC is ASPBB's solution to this. So in February of 2015, Board of Directors of ASPBB introduced the Psychology Interjurisdictional Compact, otherwise known as SIPAC, to address these concerns. Yes, I'm compressing information by member jurisdictions about increasing availability of unregulated services provided via telecommunication technologies. So basically, the goal is to protect the public. Again, for those of you who haven't taken the licensing exam for a while, what's the purpose of the State Board of Psychology? Is to protect the public. So SIPAC is a means through which each state can protect the public through the regulation of interjurisdictional practice through verification of education, training, and experience, and to ensure accountability for professional practice. And so how does ASPBB want to do this? They want to make a compromise between psychologists and licensing boards. So the compact, SIPAC, will allow greater access to care and greater flexibility for psychologists. It will allow psychologists to practice interjurisdictionally, here's the key piece, with one license from a SIPAC state. And even if you only have one license, say I'm living in Pennsylvania and I'm doing therapy with somebody in Oregon, that does not preclude you from knowing Oregon law. You still need to understand that, but you're eligible to get in and do practice with one license. It's very similar, and if people work in the federal system or know how the federal system works, so I could be licensed as a psychologist in Pennsylvania and work in a federal prison in like Wyoming without necessarily needing to be licensed in the state of Wyoming. In fact, there was a licensing board case about that recently. Not about me, but about somebody working in a federal system who was licensed in another state. So at the federal level, you're allowed to do this. So, but again, the idea is to protect the public through verification of education, training, and experience, and to ensure accountability for professional practice. Okay, so basically there are going to be two ways to do this. What we're interested in with telepsychology is the e-passport requirement. So you have to meet educational standards. So if there's any master's level people out there, I apologize, but ASPBB, the educational standard is a doctoral degree. So your graduate degree plus education, experience, and residency, there's going to be standards that they have for each of these so that you can file for your own e-passport. So you must possess a current, full, and unrestricted license to practice psychology in your home state, which is a compact state. So also to be a part of compact, or SIPAC, sorry, and to get your e-passport, you have to have no history of adverse actions. In other words, you haven't been dinged by the licensing board. You also need to have no criminal history and provide attestations in regard to your areas of intended practice and work experience, and to provide a release of information to allow for primary source verification. So the idea is that they're just not going to take you on your word. You're also going to, provide them information, say, yes, you can access these things about my world, my practice, my graduate training, my education, and there's going to be other criteria that's kind of nebulous at this point as defined by the rules of the commission. So I don't know what those are. Okay, so if you want more information about SIPAC, actually the model legislation, if you look at it, is about 40 pages long. And it's a little dicey, but again, it includes model legislation, legislative resource kit, frequently asked questions, up-to-date information. I think the only state right now, and I could be wrong, don't hold me to this, is Arizona. I think Arizona is the only one that signed up for SciPac. There's a bunch of other states that are moving forward with this initiative. So again, in Pennsylvania, we will need to work through PPA and Penn SciPac to pass this legislation. So again, first step, let's get telepsychology reimbursed by all insurance companies. So that would be step number one. I think step number two, which is more of a federal issue, we need to become listed as physicians in Medicare, because again, as I had said last time, physicians can do telepsychology into patients' homes. We cannot. So if we would be recognized through federal legislation as physicians, chances are we would then be able to see patients in their home via telepsychology. And then the third thing, which is actually second if you think about states, if you're that interested, we need to look toward SciPac to allow people to practice fully in other SciPac states. So hopefully all of that makes sense. So I'm going to get to your questions in a second. So the summary, we've broadened the scope of what informed consent means in terms of telepsychology practice. You do need to add in some information. We reviewed some risk management features, and again, the point I always like to make about risk management is some of these things involve your own risk tolerance. And then we reviewed an overview of SciPac and why this might be advantageous to psychologists who live on the borders of Pennsylvania, psychologists who move into Pennsylvania or move out of Pennsylvania. So hopefully part 3 here made a lot of sense. So now I have a couple minutes to answer questions. So question 1 is, and isn't that continuity of care? I think that's referencing if a psychologist moves, is temporarily out of Pennsylvania and they're seeing people back in Pennsylvania. Yeah, I'd say that's continuity of care. The issue, though, is you're still practicing interjurisdictionally. So that's where the hang-up is. So I'm in Harrisburg, I moved to Scranton, and I would still see my patients. It would still be continuity of care, but there's absolutely no question about is that legal or not. Once I move out of state, again, I'm not a lawyer. I don't know all the legalizations or the legalese about interjurisdictional practice, but I would say that's a lower risk if you're licensed in Pennsylvania and practicing from outside of Pennsylvania. Do you know where SciPac stands in PA? Is that something being considered by the state board or the legislator? And again, hopefully I answered that question. We as an organization need to push that forward with PPA and through Penn SciPac. But I think our first legislative goal is to get all insurances to reimburse telepsychology services. Again, if you think about it, logically even, that's our first step. I think the second step is then expanding outside of Pennsylvania. Does SciPac include other mental health professionals, providers like LCPs and LSWs? No, it does not. It's only for psychologists. Since PA is a SciPac state, actually it's not, does that mean interjurisdictional practice is allowable when screened through the migration model, for example? Okay, so PA is not a SciPac state. If I said that, I apologize because that's not what I meant to communicate. So we're not yet a SciPac state. So if we were a SciPac state, and I'm just going to use me again as an example, I'm in just say Harrisburg, Pennsylvania. My patient's in Maryland. Maryland's a SciPac state. We're a SciPac state. I could then see the person in Maryland without having to get licensed in Maryland, but I still need to know what Maryland laws are and what to do, in these types of situations. And again, SciPac is not for master's level providers. What about a college student who was seeing someone in PA but is now residing in another state? Okay, so again, I will, I'll kind of use the same frame, is that if the patient is a college student and they're out of the state for a couple of weeks on a break, you're certainly increasing your level of risk, but the risk remains somewhat low. Simultaneously, if they're in Ohio, for example, then yes, you're clearly breaking the law if they're living now in Ohio and you're doing telepsychology into Ohio, because that's explicitly banned by the state of Ohio. So again, probably the better idea is, again, depending on your risk tolerance, is while they're home at whatever state that is to find someone who can see them in the interim while they're not at school with you. That's the best solution. If that's not possible, again, depends on your risk tolerance. But if you choose to see that person, like I said, there is a certain level of risk. So for now, I need to be licensed in both states in which I live, at least until new legislation. I would say yes. If you're seeing people in Massachusetts and in Pennsylvania and you're living in Pennsylvania, I would say yes. The best risk management practice is to be licensed in all of those states that you're practicing. So you consider a lower risk in PA licensed when are in Florida and doing telepsychology with low-risk patients and would not need to be licensed in Florida. Sorry if I'm still confused about that. No, I think that it is confusing, and I don't mind repeating this, but right, if you're in Florida, you're physically in Florida, your patients are physically in Pennsylvania, you're licensed in Pennsylvania, you're probably in a good place, because again, your patients have to be located in Pennsylvania. My interpretation, not a lawyer, my interpretation is you don't have to be licensed in Florida because you're not treating the person in Florida, you're treating the person in Pennsylvania. So again, it's good that you have backup, that you know the community resources, those kinds of good things, because then that way you're practicing at the highest level, so you know exactly what's going on. Okay, next question. I may have misunderstood. Do Highmark and CBC also require that services be delivered in an approved originating location, such as a physician's office, or is that only Medicare? Great question. As far as I know, and I've talked to my provider rep at CBC, that's only Medicare. So we as licensed psychologists are practicing to the full scope of our license by our patients sitting at their home or at their place of business within Pennsylvania. Highmark and CBC permit us to do that. So it's only a Medicare requirement. Any thought about groups like Doctors on Demand? Is there more risk protection with these groups? And can you share any cases of ethical violations that have come up thus far with telepsychology? The only ones that I know of in terms of ethical violations are around Ohio. Those are the only ones that I know of. I know that there's been a couple. If you're in Doctors on Demand, again, that's my understanding, and again, I'm not 100% sure. I don't know all the ins and outs of Doctors on Demand, but that's an entity. So that's like working for a college counseling center, or you're working for a hospital, you're working for a group. That doesn't absolve you from your ethical and legal responsibilities. So if Doctors on Demand, for example, solicits patients, and this is actually this is actually a true ethical situation. I don't have time to pull it up because it's 1 o'clock already. So people are free to leave. I'm going to continue to babble. Okay, so one of these, like Doctors on Demand, was pushing the idea that you can sign up for one free telepsychology session to see what it's like. Now, if you work for Doctors on Demand and they're offering one free telepsychology service, is that ethical and is that appropriate? Because, and I actually had a back and forth with them. It wasn't Doctors on Demand, it was somebody else. But basically, if you don't know the person's insurance, you don't know their level of complexity, I mean, this is all fraught with all kinds of problems. If you're well, think about if you would try to offer somebody a free psychotherapy session. Say that you put an ad in the paper and you say, I'm going to offer people one free psychotherapy session. I mean, think about all of the complications that go along with that. Because, again, once they're your patient, they sign in for treatment, they're your patient. So if they don't have the insurance, if you're not an insurance, what's the word I'm trying to say here? If you aren't covered by their insurance and they can't afford your treatment and they tell you that they're suicidal or that they're a high suicide risk, then what do you do with them? So anytime that your organization, let's say it's Doctors on Demand, would offer that and then they would put you in the hot seat, okay, this is now your patient, that would, to me, that would be a huge problem. So I don't necessarily think that groups, unless they understand all the ethics that are involved with psychotherapy, I'm not sure that that's not necessarily guaranteeing you risk protection. So I think you'd actually have to look at their policies and procedures before signing up with them. That would be my only caveat. Okay, can you talk more about what Highmark and CBC require in terms of prerequisites? Is it virtually some type of credentialing we need to receive from them? Yes, it is. You have to have their approval. So I cannot remember, because Highmark was over a year ago and CBC was, I filled out all my paperwork 6 months ago. But basically they were things like, you're agreeing to provide the highest possible care. You're not going to violate any laws, that you're going to do everything that's in agreement with HIPAA. They had something to the effect that you've had sufficient education and experience to engage in these services. So those, I think, were the biggies. But basically, for them, it's a risk management issue. They just basically want to cover themselves, so they're not certifying you or agreeing that you can provide this service without you attesting that you're competent to do this type of work. So that's really what they're trying to do. They're trying to get you, which I think is a good thing to do, is they're trying to get you to establish that you're competent to do this type of work. So if I were an insurance company, yes, I would want that too. So that's pretty much what those, what the certification was. Okay, you're quite welcome. Okay, I work with some I think HS is high school boarding students. California and I think that's Michigan allowed for summer continuity of care. NYS was clear and quite strict in stating I was not allowed to continue care for any amount of temporary time, no matter how short, even Thanksgiving break. My teenage patient would not transfer to another therapist. Okay, so yeah, so I think that is, that definitely is an issue. So if you're working with students who travel to different states, it's technically we're not allowed to. So if you're working for a school, they're saying this is illegal, you're not allowed to do it unless you're licensed in that other state. So I can understand, again, from their risk management perspective, why they wouldn't want you to do that. So, and again, if they don't want to transfer to another therapist in their home state, all I can say is you do the best you can and document. Okay, any information on telepsychology's range of fees for clients without insurance? Again, I would say I would keep them at similar rates. I know I keep going back to this, but I think this is the best standard, is similar rates to what your face-to-face sessions are. Now, I'm shocked, and I'm saying that as transparently as I possibly can. I do know a couple people who are coaches who are not licensed. They don't have any other training or experience, and they charge close to double what I charge. So, so I guess, I would recommend you keeping it as similar as what you do in your practice, regardless of what other people do. Okay, given Highmark got rid of personal provider relations, who do you contact for the approval for telepsych? I would suggest still calling provider relations. They may not have a personal provider relation person for you, but they still have people in provider relations. I would just call Highmark's provider relations. They should help you out. hopefully. And last one, to temporarily provide private telepsych in another state. Patient is in another state. I assume I can call that state board. Yeah, a lot of state boards, though, will not give you opinions on the phone. A lot of times they want to see something in writing. And I can tell you for Pennsylvania, Pennsylvania no longer gives advisory opinions. So what that means is, let's say I was living in New York and I wanted to practice in Pennsylvania without a license, and you'd send them a letter, and they would send back, we don't give advisory opinions, something to that effect. So yeah, you can always try to call the state board. Feel free to do that. Again, I encourage people to contact their malpractice attorney, contact Sam if you have questions. You can contact me by email if you have any questions. And join the legal consultation plan that PPA offers. All of those are options for you. So for those of you who are still left on the phone call, or the webinar, thank you very much for participating. This was great, lots of great questions, and have a great day. Take care.